Good afternoon, everybody. At the outset, I must thank Dr. Gurdas Chaudhary sir and Inazal for having me here. It is very difficult to find something new in case-based discussion for PPAR. Let's see. So I think we have discussed this time and again that PPAR have a role in every step of pathogenesis of NASH fibrosis. This was discussed both by Dr. Sanyal and by Dr. Ajay Duseja sir about the PPAR agonists, and I think I was equally surprised by the first audience poll, just like you were. But I wanted to tell that there are certain natural PPAR agonists as well, which is very interesting. Some of the things which we are quite familiar, silymarin, resveratrol. A lot of studies now coming off on resveratrol now for different liver diseases. Chicory seed extract, chrysin, which is what is used by the bodybuilders for anabolism, filarin. Camel milk is another which has been shown to stimulate PPARs, both alpha and gamma. And ostol, which is again a very commonly used substance extracted from plants. So let's go to the case. 48-year-old lady underwent a diseased donor liver transplant 4 years ago for cryptogenic cirrhosis. She comes with high transaminases, SGOT of 49, SGPT of 112, GGT of 50, rest LFT, CBC, all other parameters are absolutely normal. She is on adequate immunosuppression, compliant. She's on TAC level of 4.8. The routine causes are all ruled out. Ultrasound is done, which shows grade 3 fatty liver. HbA1c is 5.6. Triglycerides 165. Other parameters are normal. There is no obstruction. Surprisingly, her BMI is 19.5. So what will you do for this patient? Can we have the audience poll? Stop TAC and start everolimus, diet and exercise, saroglitazar, pioglitazone, or evaluate further. So great. So I think it's a huge difference of opinion, but I find, okay. So we actually did a bioimpedance for this patient, and if you look at the bioimpedance carefully, the weight is just 44.8 kgs of this lady, but the fat-free mass is 22.6 kgs. So almost 20 kgs of this patient is fat out of 44 kgs. And the muscle mass is just 10.8. So although it's a poor indication, but you can see this is a patient who is very sarcopenic. 50% of the body mass is fat, although the patient is 44.8 kgs. So now what will you do? Diet and exercise, saroglitazar, pioglitazone, or vitamin E? So great. So we have divided opinion again. So this patient was started on saroglitazar 4 milligrams. And she was advised strict diet and a lot of exercise. After 3 months, she came back for follow-up. Her transaminases were normal now. Triglycerides had reduced slightly to 140, but she had actually gained 8 kg weight. And her HbA1c, which was 5.6, was now 6.2. So we were very confused. What is this response and what is happening with her? So again, what will you do at this stage? Patient has gained weight, 8 kgs. Her HbA1c has increased. The other parameters have improved. Continue diet and exercise, do nothing else. Stop the saroglitazar, or put this patient on pioglitazone, add metformin, or do something else. So So either continue diet and exercise or add metformin. I think both reasonable options. We actually went back to the history because something was not fitting in. So this patient had a habit of having late lunch around 3 o'clock. Because of the imposition on the diet, she only started having a cup of black tea in the morning. And after that, she used to do around 1.5 hours of rigorous exercise. And by afternoon, around 1 o'clock, she would get intense craving for food. And therefore, she started binge eating in the afternoon. So we decided to test her sugar level on a routine day at different levels. And at 1 p.m., her sugar was 58 milligrams per deciliter. And that is why she was getting intense craving for the food. And that is why she was having binge eating. And that is what led to the weight gain and the high HbA1c. We just modified her diet, reduced her saroglitazar to half a tablet a day. And after 3 months, her transaminases were normal. The triglycerides came down to 122. HbA1c was 5.5, and she lost 9 kg. So she continued with the diet and exercise, except that we modified her diet and her daily lifestyle eating habits, and that solved the problem. So learnings from this case was sarcopenia is an important contributor to development of NASH, and even in people with 44 kg, you can have significant NASH, and now we know retrospectively that her cryptogenic cirrhosis was probably NASH-related. It must have been the same body build right from the beginning. Reviewing history whenever there is unexplained phenomena is very important, and go into the details to find out what exactly is happening. We have to be careful about prescribing these drugs, and when we advise very strict diets to our patients, and about the timing of the meals. And I don't know whether for people with very low lean body masses, you need the same dose or the dose needs to be reduced. I think that is something which is an open question which has to be answered probably in another study. I'll go to the second case. This is a 45-year-old gentleman on an executive health checkup was found to have a BMI of 25.5. The AST-ALT was 58 and 49. Rest of the reports were very normal. A hemogram showed a platelet count of 152,000. Rest okay. He is known case of diabetes for 4 years. He's taking metformin 1,000 milligrams per day. HbA1c is 5.9. Lipids are normal. No hypertension. Creatinine normal. No proteinuria. Ultrasound shows grade 1 fatty liver. Viral markers are negative. HOMA-IR is 1.4. Autoimmune hepatitis, Wilson's disease workup done negative. No history of any other medications. Fibroscan shows a CAP value of 355 and a stiffness of 8.6 kilopascals. So what will you do next for this patient? Would you start saroglitazar, start pioglitazone, stop metformin and start saro, stop metformin and start pio, or start saro, vitamin E, and continue metformin? So majority will start saro and vitamin E with continuing metformin. I think the time given was too little for people to read the options. So the patient was started on saro plus vitamin E plus lifestyle modification. And after 3 months, HbA1c was 5.7. Lipids were normal. AST-ALT had come down to absolutely normal, 11 and 15 now. BMI 22 from 25. The only new complaint was now he was having nocturnal cough and early morning cough, which was dry. And that was the only thing which was irritating, but because of that, his sleep was getting affected. So what would you do for this patient? Assume that this is reflux related and add a PPI or maybe do an endoscopy, refer to a chest physician for the dry cough, ask for PFT, do a HRCT thorax, do the 2D echo, or do something else. Can we have the audience poll? Excellent. So I think we have, again, a divided house, but majority for adding a PPI or doing a scopy, followed by doing a 2D echo. Excellent. I think, Dr. Sanel, you have done your talk fantastically. Everybody is sensitized to cardiology. So PPI was given to this patient. No relief, however, after adding PPI. So the patient was referred to a chest physician. The HRCT was normal. 2D echo was done by the chest physician, referred by the chest physician, normal. He did a PAFT, which showed small and medium obstructive airway disease. So he was advised inhaled steroids and bronchodilators. And with that, he had a partial relief. Around 40 to 50% relief was there. So the patient came back and he said, parameters are fine, but I'm not happy. I'm still having cough. My quality of life is getting affected. Whenever I wake up in the morning, I'm still coughing. So we had the option of either changing the bronchodilator or giving steroids systemically. These were the two things which the chest physician suggested, which we didn't like, or was to do an allergy testing to see if he's sensitive to something, or take a second opinion. So we decided to actually do an allergy testing for this patient. A skin prick test was done, which did not show any hypersensitivity. IgE was done, which was normal. No eosinophils on the peripheral smear. The cough was reduced to 40%, but still present and impacting the quality of life. So what will you do next? Send to another chest specialist, stop metformin, stop vitamin E, stop saroglitazar, or stop all NASH drugs? Parameters are all normal now. Wow. So I think still, divided house. So we actually decided to stop everything. His problem was not there of cough before we had started the therapy, so we stopped everything. And the cough actually stopped in the next 7 days. It was completely symptom-free. And then we decided to stop his asthma medications, and his cough was still absent. So there was nothing which was causing the cough when everything was stopped. So we decided to reintroduce metformin because he was diabetic. We thought that that was the most important drug to be given to him. And he did tolerate it well. And then we reintroduced saroglitazar, and the patient started coughing again in 5 days. And it was stopped again, and he again became completely free of cough in next 7 days. So when we reviewed the literature, actually all these three drugs, vitamin E, metformin, and saroglitazar, have been reported to cause bronchial asthma. And therefore, we have to be alert and aware for unusual adverse events for these patients. So whenever you have an unexplained phenomenon which is started after the drug, we must think of this as an adverse event. And when I actually looked at the literature, this has been reported by Ratnasai and group, who have done the majority of the studies for saroglitazar in dyslipidemia and diabetes. They've reported 7.3% patients having asthma with saroglitazar 4 milligrams and 2.4% with saroglitazar 2 milligrams. So I think this is something which we have to keep in mind. It's rare, very unusual, but if it happens, we have to be alert, simply because now it is being used so rampantly that the denominator has increased so much that we will get few isolated numerators of bronchial asthma because of these drugs. Thank you very much.